of the hemato-oncology. For that, we first of all request the chairpersons to come to the stage. For that, Dr. Ataullah, please kindly come to the stage. Dr. Murad Ali, kindly come to the stage. Dr. Qazi Ikram, kindly come to the stage. Dr. Naseeb, kindly come to the stage. The honorable chairpersons have taken these chairs. We are thankful for that. We are beginning our session of hemato-oncology. So the first topic that we are going to discuss is about the prevention and treatment of tumor lysis syndrome. And for that, we'll be requesting Dr. Ishfaq Ahmed Shah to come to the dais and start their topic. Thank you so much.
Assalamu alaikum. I am Dr. Ishfaq Ahmed Shah, working as an assistant professor of medical oncology in Khyber Teaching Hospital. Today's topic of presentation would be tumor lysis syndrome. I would also like to thank PSP CON to providing me an opportunity to present tumor lysis syndrome. So starting with the tumor lysis syndrome, because we commonly see different oncological emergencies, and one of the most common oncological emergencies in hematological diseases is tumor lysis syndrome. And management of this tumor lysis syndrome is very critical and very crucial for the patient and for us and for the family as well. So we will start with the scenario. A young 18 years old male patient who presented to the emergency department with a high-grade fever, shortness of breath and generalized seizures. On examination, patient was febrile with generalized lymphadenopathy, hepatosplenomegaly. On chest examination, he was having bilateral coarse crepitations, GCS of 9/15. On lab investigations, patient was having HB of 9, WBC of 3,42,000 and platelets count of 54,000. LFTs were normal. RFTs creatinine of 3.4 mg per dl, uric acid of 22 mg per dl, and serum electrolytes of 6 millimole per liter. So what is your diagnosis? It is an acute leukemia, CLL, acute tubular necrosis, or tumor lysis syndrome. So it's a tumor lysis syndrome because the patient is having raised uric acid, the patient is having raised WBC count, patient is also having hyperkalemia, deranged RFTs. So these all findings favors tumor lysis syndrome. So these are the learning objectives. So starting with the tumor lysis syndrome, it is an oncological emergency and it is caused by the massive tumor cell lysis. And once there is a cell lysis, we all know there are some intracellular electrolytes which comes out from the intracellular to the extracellular space, and it leads to increasing the amount of potassium, phosphate and nucleic acid into systemic circulation. Sometimes it is because of the treatment. When we start treatment with steroids, with specific chemotherapy, we commonly see tumor lysis syndromes. But sometimes we see patients who presented initial presentation with spontaneous tumor lysis without taking any treatment. So it can be a spontaneous or it can be because of the treatment. This is chemotherapy. So rapid lysis of the tumor then leads to the release of the massive quantities of intracellular contents into the peripheral circulation. The intracellular contents goes into the systemic circulation, leading to hyperkalemia, hyperphosphatemia, hyperuricemia, and there is a secondary hypocalcemia because what phosphate do is it binds to the calcium and causes calcium phosphates by the method of or the mechanism of saponification. So it leads to secondary hypocalcemia, and then all these findings leads to deranged renal functions. So we will discuss by different. Number one is hyperuricemia. What is hyperuricemia? When there is increase in the uric acid, and it is because of the catabolism of the pyrene nucleic acids to hypoxanthine and xanthine and then uric acid through the enzyme xanthine oxidase. So the marked increase in the uric acid excretion can result in the precipitation of uric acid in the renal tubules, can induce renal vasoconstriction and impair autoregulation and decrease renal blood flow and inflammation, resulting in acute kidney injury. Uric acid is poorly soluble in water, particularly in usually acidic environment in distal tubule and collecting system of the kidney. Overproduction and overexcretion of uric acid in tumoral syndrome can lead to crystal precipitation and deposition in the renal tubules and acute renal acid, uric acid nephropathy with acute kidney injury. What is hyperphosphatemia? Normally, there are the phosphate is normally intracellular and it is 4 times higher in the neoplastic cells or the malignant cells. When there is rapid tumor turnover or breakdown, then it leads to hyperphosphatemia, and then we discuss already it leads to the secondary hypocalcemia because of the calcium phosphate formation by saponification, and this hyperphosphatemia with calcium phosphate deposition in the tubules can cause acute kidney injury. In addition, precipitation in the heart may lead to cardiac arrhythmias. And since the widespread use of hyperuricemic drugs, calcium phosphate deposition rather than hyperuricemia has become the major mechanism of acute kidney injury in tumoral syndrome. So what is xanthuria and how it occurs? When allopurinol is started to this type of patient, it blocks the xanthine oxidase. And when then xanthine oxidase enzyme has been blocked, it blocks, then there is increased formation of hypoxanthine or xanthines. And thus, the hypoxanthine is water soluble and xanthine is not that much water soluble. So it is accumulated in the tubules, resulting in the xanthine nephropathy or xanthine stone formation. Xanthine concentration is not increased by resburicase, which is now the preferred options. So coming to the risk stratification, there are the tumors which are classified on the high risk, as per the high risk, intermediate risk and the low risk tumors. So those tumors which have the high risk of developing tumoral syndromes are the advanced Burkitt lymphoma, advanced leukemias, early stage leukemia and Burkitt lymphoma with elevated LDH, ALL with WBC count of more than 1 lakh, or if increase of LDH from the baseline is 2 times the upper limit of normal. Diffuse large B-cell lymphoma and Burkitt disease with LDH of 2 times upper limit normal, and ML with WBC of more than 10,000. So these are the high-risk tumors. Coming to the intermediate, if the patient is early stage having leukemia or Burkitt lymphoma with LDH of less than twice the upper limit normal, ML with WBC between 25,000 and 1 lakh, ALL with WBC of less than 1 lakh, and LDH of less than twice the upper limit of normal, and diffuse large B-cell lymphoma with baseline increase in the lactated dehydrogenase of twice the upper limit of normal, but not the Burkitt disease. In low-risk disease, these are the tumors. It comprises of solid tumors, the small cell lung carcinomas, the neuroendocrine tumors can cause tumor lysis syndrome, multiple myelomas, indolent lymphomas, CLL and CML can also cause, in very rare cases, can cause tumor lysis syndrome. So how we label a patient as a tumor lysis? There is a criteria which is known as Cairo-Bishop criteria. In Cairo-Bishop criteria, it is divided into 2, the laboratory tumor lysis syndrome and the clinical tumor lysis syndrome. If the patient is having 2 or more than 2 of the listed metabolic abnormalities within 3 days before or 7 days after initiation of treatment, like hyperkalemia more than 6 milligram per liter, or hyperuricemia of more than 8 milligram per dl, or hyperphosphatemia of more than 4.5 milligram per dl, or hypocalcemia of less than 7 milligram per dl, or if there is a 25% increase from the baseline, and for calcium if there is a decrease, 25% decrease from the baseline. For clinical tumor lysis syndrome, acute kidney injury is first sign, second is the seizures, and the third one is the cardiac arrhythmias or sudden death because of the hyperkalemia, because of the hyperuricemia, and can lead to the cardiac arrhythmias and sudden death. So how do we treat tumor lysis syndrome? This is the general approach. In general approach, if the patient is having low risk disease, it will depend on the clinical judgment and monitoring. If the patient is having intermediate risk, start allopurinol 100 to 300 milligram per hour every 8 to 12 hours. Start 1 to 3 days before the start of cytotoxic chemotherapy. Continue for 3 to 7 days after cytotoxic therapy based on ongoing risk. Hydration, it should be 2.5 to 3 liters per meter square per day. And strict input and output record. Monitored potassium, phosphate, calcium, uric acid, LDH every 8 to 12 hours. For high-risk disease, which we have already discussed in previous slide, consider pre-phase cytoreductive therapy prior to starting primary therapy. Resburic 3 mg to 6 mg IV over 30 minutes once. Draw uric acid level 4 hours later, and then repeat resburic dose if clinically necessary. Hydration is 3 liters per meter square. Strict input and output record, and monitor potassium, phosphate, calcium, uric acid, LDH every 6 to 8 hours. So coming to the specific one, how will we treat hyperphosphatemia? Strict phosphate intake, avoid IV and oral phosphate, and start patient on phosphate binders like calcium acetate, calcium carbonate, and if the patient is having severe hyperphosphatemia, refer the patient for urgent hemodialysis. For hypocalcemia, if the patient is asymptomatic, do not treat hypocalcemia. If the patient is symptomatic, always treat hyperphosphatemia first. Once the hyperphosphatemia is being treated, then treat the patient hypocalcemia. For hyperkalemia, if the patient is having moderate and asymptomatic, avoid IV and oral potassium, ECG and cardiac rhythm monitoring should be done. And if the patient is having severe hyperkalemia, start the patient with calcium gluconate, and it should be given 1 gram with slow IV infusion in large veins, may be repeated after 5 to 10 minutes if ECG changes persist. For temporarily shift the potassium into the cells, give in IV insulin and dextrose. IV insulin dextrose is given, regular insulin is 10 units IV plus 100 ml of 50% dextrose solution, and it may be repeated after 30 to 60 minutes. Monitor finger stick glucose closely. And the last one is if the patient is having hyperkalemia, one should go for beta-2 agonist inhalation as well. And the last one, if there is no improvement with this intervention, go for hemodialysis. So we are using different type of drugs, the allopurinol, which is xanthine oxidase inhibitors, the febuxostate, and the third one is resburic. I will just go through these slides. Allopurinol is an analog of purine-based hypoxanthine, which lowers uric acid by inhibiting xanthine oxidase. Its active metabolite oxypurinol also inhibits xanthine oxidase. Because both inhibit uric acid synthesis and have no effect on pre-existing uric acid levels should usually do not fall until after 48 to 72 hours of treatment. Inhibition of xanthine oxidase lead to increase in the plasma hypoxanthine and xanthine levels with increased renal excretion of both metabolic products. And oral allopurinol bioavailability is 50%, and alternatively intravenous allopurinol may be administered if available. Allopurinol should be discontinued if allergic reactions such as skin rashes and urticaria occurs. Febuxostate is an alternative to allopurinol to prevent TLS in patients at intermediate to high risk for tumor lysis syndrome. It is given orally, potent selective inhibitor of lanthanum oxidase. Dose adjustment is not needed in patients with mild to moderate renal impairment, while in allopurinol their dose should be adjusted as per the renal derangement. And there are few drug-drug interaction with febuxostate than allopurinol. Coming to the resbuticase part, resbuticase is available in two strengths, in 1 ml vial and 5 ml vial, and it comes at 1.5 milligram per ml. So in 5 ml it is 7.5 milligram. For prophylaxis we give 3 milligram state dose, and it can be repeated if needed. In treatment of TLS, once the patient is presented with frank TLS, then one can go for 0.2 milligram per kg body weight of the resbuticase, and it can be given IV once daily for 3 to 7 days as necessary. What are the side effects? Very common is headache, diarrhea, nausea and vomiting, and fever. It can also cause fever. Common is allergic reactions, and uncommon side effects are hemolysis or hemolytic anemias and bronchospasm as well. So contraindication to resbuticase treatment is allergy to resbuticase, G6PD deficiencies, and methemoglobinuria or history of hemolytic anemia. So indication for renal replacement therapy in tumor lysis syndrome is severe oliguria or anuria, intractable fluid overload, persistent hyperkalemia, and hyperphosphatemia-induced systemic hypocalcemia. So any questions? Thank you.
Now I will request Dr. Abdul Rahman to come to the stage and to talk about therapeutic approach and diagnosis of hypercalcemia of malignancy.
I am Dr. Abdul Rahman, working as assistant professor in Government Medical College, Yaristan Khan. First of all, I thank you, Pakistan Society of Physicians, for providing me the opportunity. I would also present the hemato-oncology related complications. These are also would be important for the general medicine trainees and people because they also present to our wards. Because they take these chemotherapies and these are the complications they present to our ward. So one of the complications, as I am going to discuss with you, is the hypercalcemia. Now, as you know, this is the hypercalcemia definition. It's divided into mild, moderate, and severe. As you know, it's mild is 10 to 12, and then if it is more up to 14, and if it is more than 14, then we call it severe or life-threatening. So this is a mechanism. I don't want to bore you with this pathophysiology because आखिर है तो बस आप लोग थके हुए हैं. So you know all these basics, the osteoblast, how tumor cells secrete the PTH-related proteins and all these tumors. So next, the mechanism. I won't go into the details because mostly this parathyroid-related protein is the most common mediator जो ट्यूमर secrete करते हैं और उसके बाद जो है इस तरह hypercalcemia होता है. साथ में tumor produced cytokines like TNF and other TGF-like cytokines, but majority is PTH-related proteins. And they may also secrete other mechanisms, calcitrol, prostaglandin, and in some very rarely there may be ectopic parathyroid hormone production, PTH, rarely. So, and these are all other mechanisms. So there are multiple mechanisms. So it's 20 to 30% of the patients may have, so it's a big number. So this is overlooked most of the time in our medical units. The oncology people have this in their mind, but in the medical units they may be overlooked because so it's a big number. This is 20-30% of the patients may have hypercalcemia, and this is the poor prognosis, mostly multiple myeloma, and then so we should how to pick them. Early diagnosis is important. How to pick them? Like they may present with the renal complications, as you saw. This is polyuria, polydipsia, and RTAs and all these other complications they can present. And like GI complications, they can present nausea, anorexia, constipation, pancreatic, peptic ulcers. Musculoskeletal, we know they can present with weakness, bone pains. They can have, like they may be very mild, but hypercalcemia causes short QT intervals, and they may cause arrhythmias as well. And as you know from the cyclic moans from the hypercalcemia, the abdominal groans and the cyclic moans of medical school, the anxiety, depression, cognitive symptoms they can have. So how to diagnose them? As you know, sometimes the calcium may not be raised, but we should, if most of the patients with oncology, they have low albumin. So you should have a corrected albumin as well, if the albumin is low. And then you can have ionized calcium. And then another differential diagnosis is primary hyperparathyroidism. So how to differentiate between, so in that, the PTH is suppressed, while in primary hyperparathyroidism, the PTH is high. So you should take a detailed history of the medication. They will be taking the drugs, the foods, and then the physical examination is important. So I am skipping these slides. So the laboratory test should be serum calcium, corrected calcium if the albumin is low, then there is a special formula for that. We do the PTH that is suppressed, urea creatinine to know the nephropathy. So imaging studies should be done to know the basic tumor, we should know how which tumor is involved. So management, this is the important thing, like how to manage them. This is the important slides. So if the patient, so the hydration, the bisphosphonates, calcitonin, denosumab, corticosteroid, and the treatment of the underlying therapy is the mainstay of treatment. So IV hydration, if the patient is a mild hypercalcemia, it's like up to more than 10 to 12. So IV hydration, but very cautiously if the patient is having cardiac problems. So you start with a normal saline, and so we give 200 to 3 ml per hour to maintain adequate urine output of more than 100, then restoring the intravascular volume and increasing urine. And so you can add the loop diuretics as well, but before that, the proper hydration is important. And when the patient is, if the patient is having a very high calcium level, and you want to suddenly drop the calcium, so calcitonin is used, and it's a very fast-acting medication for that. So another drug is bisphosphonates. Zoledronic acid you can give, but it takes 2 to 3 days to work on that. So in some of the conditions, like in renal failure, when there is nephropathy along with that, so it is contraindicated in that conditions, so we can use the zoledronic acid for that. If there is contraindication to the zoledronic acid, or the patient is having renal failure, then you can give the denosumab, which acts by inhibiting rankles and should be considered when there is no response to zoledronic acid. Or if the patient is, there is refractory hypercalcemia, you have given the zoledronic acid and that is not working, and it's refractory. So then you can give the denosumab. So it is given regular patient. They also use it on regular basis in tumors like multiple myeloma. Steroids can be given in those patients who are having the vitamin D production, such as lymphoma. They give the steroids along with that, and steroids is also given in multiple myeloma to suppress. So prognosis of malignancy-related hypercalcemia depends on the underlying cause. So if there is hypercalcemia, prognosis is mostly poor. So the key take-home message is for general medicine people. So early detection is important. If the patient can present with confusions, fatigue, it may be early. You should suspect them. And stabilization is important, and you can hydrate them. Hydration is very important. Plus minus loop diuretics and bisphosphonates are the first line agents. Zoledronic acid is the most effective agent. If it is contraindicated or if it is not working, then you can give denosumab, and calcitonin may be used in those cases when you want the rapid correction of the calcium. And obviously you have to address the underlying malignancy. And in those patients who are nothing is working, and you can use the hemodialysis. So multidisciplinary team is important. You have obviously, if the patient has presented to medical ward, you should involve the nephrologist, you should involve the oncologist, and so. Thank you.
I would like to invite Dr. Muhammad Kashif Afridi for discussion about bleeding complications related to hemophilia.
Assalamu alaikum. I am Dr. Muhammad Kashif Afridi, working as Assistant Professor at Department of Pediatrics, Private Teaching Hospital, Peshawar. I am humbled and thankful to PSP CON for giving me the opportunity to talk. I will be talking about hemophilia, its basics, and management of complications. So, regarding hemophilia, these are X-linked recessive bleeding disorders that lead to decreased blood levels of functional protein factor J and factor 9, factor 8 in hemophilia A and factor 9 in hemophilia B. The incidence of hemophilia A is 1 per 5,000 males, and incidence of hemophilia B is around 1 per 1,000, 30,000. So hemophilia A accounts mostly for 80 to 85% cases of all the patients presenting with hemophilia. Regarding clinical course of hemophilia, it should be suspected whenever there is unusual bleed in a male patient. The frequency and severity of bleeding depends upon the levels of the factors, and the median age of presentation is usually 10 months. That corresponds to the age at which the infant becomes mobile. Clinical presentations of hemophilia can present in bleeds anywhere. Most common is joint bleed, hemoarthrosis, gum bleed, mouth and nose bleed, intracranial bleeding, muscle bleeding, hematuria, and post-surgical, post-traumatic bleed. The bleeding severity depends upon the levels of clotting factors. In severe cases, their factor level is less than 1% and they present with spontaneous bleed. While in moderate cases, the factor levels are from 1 to 5 and their bleeding presentation is variable, can be after mild trauma. In mild cases, the factor level is from 5 to 40% and they usually present with bleeds after trauma or surgery. High-risk female carriers who have X inactivation lionization, they can present with bleed in obstetrical hemorrhage and gynecological cases. The severity of, if we talk about severity of hemophilia, so 70% of the hemophilia A cases are severe, while moderate and mild are 15%. Hemophilia B, 50% cases are severe, mild and moderate are equal to the severe hemophilia B. So severity is more in hemophilia A. Regarding common sites of bleeding in hemophilia, the serious bleeding includes joint bleed, hemarthrosis, muscle bleed, especially compartment deep, like iliopsoas, cough and forearm, mucous membrane, mouth, gums, nose, and genitourinary tract. The life-threatening bleeds include intracranial, intraspinal, retropharyngeal bleeds, and retroperitoneal bleeds. They are life-threatening. If we talk about the frequency of bleeding at different sites, so most common is hemoarthrosis. It occurs in 70 to 80% of the cases. And the hip joint are involved more, like elbow and knee, as compared to trapezial joint, shoulders and hips. In muscle, the frequency is 10 to 20%. Other bleeds accounts for 5 to 10% of cases, while intracranial bleed and CNS intraspinal bleeds are less than 5%. Regarding diagnosis of hemophilia, it should be suspected whenever there is a family history with history of bleeding in maternal uncles or kids of maternal aunt, and there is abnormal bleeding, prolonged APTT, and then followed by mixing studies and factors level. So factor level will confirm the diagnosis, and other causes of bleeding have been ruled out. Differential diagnosis of hemophilia A includes, it can be lab error. Prolonged APTT can lead to lab error, hemophilia B, type 2N of the one disease, and acquired hemophilia in cases of underlying autoimmune diseases, pregnancies, and malignancies. While differential diagnosis of hemophilia include vitamin K deficiencies, liver diseases, and hemophilia A. This slide shows the treatment line of hemophilia starting from whole blood transfusions in 1940 with introductions of fresh frozen plasma in 50s, and then followed by cryoprecipitates in 60s, followed by plasma-derived factors, 8 concentrate, and then usually heat-treated plasma-derived factor 8 followed by gene therapy that was not successful that time, and now we have recombinant factor 8 factor that half-life had been prolonged after fusion with Fc portion of immunoglobulin and pegylation. Different prophylaxis regimes have been used to prevent bleeding. So there are two types of prophylaxis. One is bleeding prophylaxis before bleed, and the other is on demand, that are given after bleeding. The continuous prophylaxis have different types. Primary, we call it primary prophylaxis if it's given prior to second joint bleed and before 3 years of age. While secondary prophylaxis if it's given before 2 joints bleed but no joint disease, and it's called tertiary prophylaxis if it is given after the joint disease. And one is intermittent prophylaxis if you are giving prophylaxis but the doses are less than 45 weeks per year. Targeted prophylaxis is that whenever there is high risk activities, contact sports, or there is surgery, so this is targeted prophylaxis. On demand is when the bleeding occurs. Two different protocol mostly used are Malmö protocol that include 25 to 40 international units per kg of factor 8 that are administered 3 times a week for hemophilia A and 2 times per week for hemophilia B. Another protocol is UTREC protocol that include 15 to 30 international units given 3 times per week in hemophilia B A and 2 times per week in hemophilia B. Different studies have shown that prophylaxis versus on-demand treatment, prophylaxis have better outcome. The first randomized controlled studies performed in 2007, which shows that the annual joint bleed rate was 0.2% in prophylaxis, patient receiving prophylaxis versus 4.65 in the patients who are receiving on-demand prophylaxis. This is another study performed in 2017 which shows that the annual joint bleeding was 0.3 in patient receiving prophylaxis and it was 27.3 in patients showing on-demand prophylaxis. And the quality of life was better in patient receiving prophylaxis. Types of different treatment have been given. First is replacing the missing protein. It includes factor concentrate and gene therapy. Another is the human monoclonal antibodies, emicizumab, that mimics factor 8 role in kinase complex. It bridges activated factor 9 and 10 to generate activated factor 10. Another are bypass agents that includes recombinant factor 7, activated and activated partial prothrombin complex concentrate. Desmopressin that release the factor 8 release from the storage in endothelium, antifibrinolytic that stabilizes clots by inhibiting fibrinolysis and rebalancing hemostasis, phytosteran interfering RNA molecule that inhibit endothelium 3, and TFPI tissue factor pathway inhibitor that is recently FDA has approved martesivimab in October 2024. Regarding treatment, if we classify, there's some we can use for bleeding and prophylaxis. These include factor replacement, bypass agent, cryoprecipitates, and FFPs where there is affordability and availability issues. The treatment that can be used only for bleeding are desmopressin and antifibrinolytic, and for prophylaxis, emicizumab, gene therapy, phytosterone, and tissue factor pathway inhibitors can be used. Some of these are investigational, like gene therapy, phytosterone, and TFPI inhibitors. Factor replacement, the standard half-life product that are plasma-derived and recombinant factors, their half-life can be prolonged if they are fused, FC portion of immunoglobulins are fused करते हैं, तो इसका half-life 1.5 times है. और pegylation albumin fused जो recombinant factor है, they have factors to 5 times greater than normal factors. These are the dosing and requirement in various bleeds. Like for hemarthrosis, we require factors level up to 30 to 50% minimum. One thing important to note is that factor 8, 1 unit of factor 8 increases 2% of the factor, while in factor 9, 1 unit of the factor 9 increases 1% of factor. So depending upon the different doses are used. In hemarthrosis, factor 8 is given as per the mentioned doses. And other supportive therapy like rest, immobilization, cold compression, and elevation. Cold compression should be given for 15 to 20 minutes every 4 to 6 hours. And whenever there is no response after 24 hours, the joint is still bulging, tense, and there is neurovascular compromise, we should go for arthrocentesis under factor 8 or factor 9 cover, that is 30 to 50 international unit per kg. And if you look at the response, if their pain subsides within 8 hours, full pain and full all the symptoms have been subsided, within 8 hours it is termed as excellent response. In muscle bleed, the serious part is that if the bleed is into the compartment like forearms, calf, and iliopsoas, that can be limb threatening. So these patients should receive immediate factor 8, and the level should be maintained for 2 to 4 days in cases of severity. In oral mucosa, local therapies like pressures, bandages, packing, that can be done along with antifibrinolytic therapy, and factor 8 can be given as per the mentioned doses. In GIT bleeds, we use 100% initially and then followed by 50%. Antifibrinolytic therapy can be helpful, and endoscopy can be performed to look for the site. In hematuria, patient presenting with painless hematuria, only complete bed rest and good hydration can cure. But persistent hematuria and painful hematuria, factor 8 and factor 9 should be given. There are role of prednisolone 1 to 2 milligram per kg. Fibrinolytics should be avoided, antifibrinolytics, because of renal clot formation. In CNS bleed, we should keep the factor level up to 100%, and it should be maintained up to 14 days in some cases, 7 to 14 days depending upon the severity and symptoms. And in cases of elective surgery, inhibitors should be minded, because in cases of inhibitors, we will discuss later, we need extra doses and large doses of factor 8. Retroperitoneal retropharyngeal abscesses are life-threatening. Those patients should be admitted and should receive factor 8 till they are asymptomatic. Desmopressin increases factor 8 by release from the endothelial cells. They increases the plasma factor 8 level by 2 to 5 folds. IV dose is 0.3 microgram per kg, maximum up to 25 microgram, that is administered in 25 to 50 ml of normal saline over 15 to 20 minutes. Subcutaneous is as effective as IV in patients, especially younger infants, where IV cannulation can be different. In cases of baby, can use subcutaneous. Intranasal vasopressin is also available, that can be used after 6 years and above. Recommended doses include one puff that include 150 microgram for less than 50 kg, and for more than 50 kg, 2 meter doses or 300 microgram intranasal vasopressin should be given. Regarding side effects, common includes flushing, headache, and nausea, but free water should be restricted because it can lead to hyponatremia and fits. So usually wet sweats contraindicated in younger children. Antifibrinolytic therapy inhibits fibrinolysis by preventing activation of proenzyme plasminogen to plasmin. It prevents clone degradation, especially in fibrinolytic rich area like oral cavity, nasal cavity, and reproductive tract. We usually use our transaminic acid 20 to 25 milligram per kg orally or 10 milligram per kg IV every 8 hours. They are contraindicated in case of hematuria due to renal clot formation, and don't combine with factor 8 inhibitor bypass agent because there are risk of thrombosis, especially with PCC prothrombin complex concentrate. Inhibitors, this is a complication of hemophilia. They are utilizing early antibodies directed against factor 8 that is given exogenously. Inhibitors are quantified by Bethesda assays. If the Bethesda assay shows less than 5 Bethesda units, they are low responder. While where the Bethesda unit score is more than 5 or 5, they are high responders. And inhibitor formation mostly occur in severe hemophilia, that is 30% of severe hemophilia A cases, while in 15% of mild to moderate hemophilia, and it is less than 5% in cases of severe hemophilia B. Low responder can be treated by high doses of factor 8, that is 100 unit per kg, and repeat doses of 100 unit per kg 12 hourly or per day. In cases of high responder, if the Bethesda score is less than 20, we can give factor 8 infusion and the inhibitor can be neutralized. But if it is 20 or more than 20, then factor 8 will not work. And in that cases, we will give prothrombin less concentrate. We have not available here, so we give factor 7, Nova 7 or REO7. Usually we give at low 90 microgram per kg every 2 hourly for 2 to 3 doses till hemostasis is achieved. Another therapies are 200 microgram per kg for 2 to 3 doses, or single high dose of 270 microgram per kg in cases of outpatient settings. There is a mecuzumab that is monoclonal antibodies. It mimics factor 8 roles in kinase complex. It is given bi-monthly or monthly subcutaneously. And studies have been performed in Lahore and Karachi hemophilia center. What is very expensive. That's how we are not. Regarding management of inhibitors, how to relieve inhibitor, plasmapheresis with immunoabsorption, but it causes fever and hypotension because tetrafocal pollen is used. We are not doing this immune tolerance induction that involve frequent administration of factor 8 concentrate to reduce immune tolerance to the exogenous factor 8. Different regime used for immune tolerance induction are high doses of factor 8, 100 units per kg twice daily or 200 units per kg per day. Another regimes are intermediate doses that equal to 50 to 100 units of factor 8 per kg per day. An alternate day low dosage include 25 to 50 units per kg alternate day. Rituximab can be used to manage inhibitors, that is anti-CD20 antibodies with or without immune tolerance induction. Something about chronic complications, we can have chronic arthropathy, that is due to recurrent bleeds, there is synovial membrane proliferation, cartilage damage that can lead to chronic arthropathy. So multidisciplinary team should be involved. There are risks of transmission of infections like hepatitis B, C and HIV due to heat treatment and pasteurization and different virus inactivation treatment of the factor 8 products. The transmission has been decreased. But not here as we are using cryoprecipitate and FFPs2, so care should be taken about this and these patients should be screened. Supportive care, avoid trauma including anticipatory guidelines to take safety measures like wearing helmets, seat belts, and violent contact sports should be avoided in male, but healthy lifestyle should be ensured to avoid obesity and weight gain. And patient with hemophilia should avoid aspirin and NSAIDs intramuscular injections. Thank you.
So requesting for quick break. What we can do now is, because of shortage of time, we can request the honorable chairpersons to have their precious comments about the hemato-oncology session, and then after that, those who want to stay, they can stay, and those who want to go for prayer, they can go for prayer. During that time of prayer, we will have our last speaker who will be discussing with us about the management of febrile neutropenia. I request the honorable chairpersons to kindly give your precious comments about today's session of hemato-oncology.
Medicine. So we are thankful to the PSP for bringing such important medical oncological emergencies to this forum. I think all the respected speakers have explained very well. One question in my mind is regarding the fact that when the patient with tumor, regarding the tumor lysis syndrome, the presenter must be sitting here. Can we give prophylactic xanthine inhibitors or febuxostat before starting the therapies to decrease the chances of TLS or otherwise?
Yes, it is recommended. One has to start. It depends on the renal function as well. If the patient is having renal derangement, then better is to go for febuxostat rather than allopurinol, because in renal derangement one have to dose modify for allopurinol rather than febuxostat. So it is recommended one have to start a patient on xanthine oxidase inhibitors with prophylaxis. It is common, and we are starting every patient of acute leukemias, lymphomas, and we are putting the patient on xanthine oxidase inhibitors.
And do you have any proper limit till which you should bring the, like a sodium cut-off line?
uric acid. So xanthine oxidase inhibitors are, it is not for those patients who presented with the tumor lysis syndrome, because the xanthine oxidase inhibitors does not work when the uric acid goes beyond the normal limit, because it inhibits the xanthine oxidase and then it does not form the uric acid. But once it forms, it has nothing to do with the already formed uric acid. So one have to go for uric acid in such type of cases rather than go for. But in our setup, what we do is we start the patient on IV fluids along with xanthine oxidase inhibitors, because uric acid is much expensive. It costs around about 90,000 rupees. So we are giving an options to the patient, because most of the time patient present with tumor lysis syndrome, and the ideal treatment is uric acid in such patients. But the patient does not afford. So what we do is we start the patient on IV fluids, xanthine oxidase inhibitor, and we repeat every 12 hours in the morning and in the evening the uric acid, the potassium, these phosphates, and the calcium as well. So these are what we do in our setups.
Thanks to all the speakers for refreshing and adding to our knowledge about hemato-oncology. You know, hemato-oncology is a separate subspecialty, but the internist should be proud of their specialty, because it is the internist who is knowing and should know something about everything. Again, it depends upon the setup where you work, where you are in a tertiary level hospital, where you have a separate unit for hemato-oncology, along with all supporting wards and stuff, or you are working in periphery. But even in periphery, a good physician with good knowledge of hematology can make, on basis of history investigation, the diagnosis, and I will and we do at Bannu, we refer them to the center, the hemato-oncology unit, and they get proper treatment, and it is free of cost. And then after that, for follow-up and for complication, definitely they lend it to our units at medicine department, pediatric department. So it is must for the internist to know how to manage the complications. Thank you.
Speakers, Dr. Ishfaq, Dr. Abdul Rahman, Dr. Kashif, they delivered very precise and in time insight to the very important topic regarding oncology. As a general physician, we do face these emergencies on and off, but most of the time we don't notice them. They are missed, and especially in tumor lysis syndromes, they are the killers, the hyperkalemia. If we do miss it in time, the history is tricky. I would say if a very recent chemotherapy session is received and the patient suddenly deteriorates, so always expect that this is a tumor lysis syndrome. And hyperkalemia must be the first priority, because it can lead to fatal arrhythmias and it can kill the patients within minutes. So these emergencies regarding oncology, there are frequent cases, so we should be very vigilant on that. Extending one question from Dr. Ishfaq, as he is dealing these cases, hyperuricemia in this tumor lysis syndrome, what is the best one, whether allopurinol or febuxostate?
Both are the same. Xanthine oxidase inhibitors. But in our setup, I think as per books, it is an expensive one. The febuxostate is an expensive one than allopurinol. Otherwise, what I am doing is I am using febuxostate instead of allopurinol, because there are no dose modifications in the renal derangement. So I prefer the febuxostates rather than allopurinol.
would just like to comment on Dr. Abdurrahman session. It was really, he presented in a nice way. I would recommend and request all the PGs to have an eye on hypercalcemia, especially in the geriatric patient, because everybody who presents with polyuria, polydipsia, and he is not having, it is not diabetes, because in the elderly patient, it could be the first presentation of some underlying malignancy. So it is very important to keep an eye on that and to look for the calcium level. And regarding tumor lysis syndrome, yes, we receive a lot of patients, and usually in most of the cases they are misdiagnosed as having septicemia with AKI. And later on the workup, it is found that the patient is having some underlying syndrome, some underlying tumor, and that tumor lysis syndrome is a presentation. So, working in the general medicine ward, this is very important to keep your eyes open and mind open to think about each and every possibility. And hemophilia, yes, Dr. Kash, he elaborated in a nice way from the basic to the advanced level. Thank you so much. It was really good course, good session, and we learned a lot. Thank you.
We can have a prayer break. While we'll be having, during that break, we'll be having our last speaker for today's session, Dr. Badr Mahmood. He will be discussing management of febrile neutropenia with us.
Yes.
Chairpersons, they want to have lunch, they can have lunch during that time, because we'll be having online session now. They should go to PGMI faculty. Thank you. Thank you.
But my major concern and focus will be early recognition and management, so that we have some conclusive evidence-based discussion and there is some takeaway points. The objectives, as I mentioned, we will go through these headings. The definition is febrile neutropenia is defined as single oral temperature measurement of 33.3 single temperature or a temperature of 38 degrees centigrade sustained for 1 hour with an absolute neutrophil count of less than 500. There is another limit to the definition, that is called ENC, that is expected to decrease to less than 500 over next 48 hours, but we will talk about this kind of definition later on. Please note that ENC means absolute neutrophil count, and FN I will be referring in my presentation to febrile neutropenia as shown. Well, this slide is not only etiological, it also clarified the definition that fever with neutropenia. Please note that it's both way. The neutropenia can give the opportunistic infection like viral, bacterial, fungal, others are autoimmune conditions, and that neutropenia can give as a causative cause for fever. At the same way, fever can suppress marrow because of all these infections and give neutropenia. So it's not only the etiological slide, but also explain the definition of the FN. Incidence and mortality, it's not very equidistant. The prevalence has been very varied since the incidence of all conditions causing suppression to marrow or neutropenia has been correlated, and it's not been unified all over the geological prevalence. So the incidence in particular cases like with chemotherapy, it has been 8 patients out of every 1,000. In hospital, mortality rate is 10 to 20%, considering that there are very few patients who develop febrile neutropenia. 10 to 20% is a very high rate. Neutropenic fever with leukemia has wide prognosis, as all cause mortality up to 15%. With vital organ involvement, mortality can be as high as 59.9%, which is very high. It's been classified depending upon ANC into mild, moderate, severe. In some cases, an ANC of less than 100 is considered as very severe. The etiology, I won't go into the details, but the prime point is there is suppression of the marrow because of any cause or it can associated neutropenia. There is one entity that is called implicit neutropenia or cyclic neutropenia. Later on, we will get into these details. Apart from that, the nutritional cause of neutropenia, lack of vitamin B12, folate, copper, that is also the same way there is a narrow arrest and that leads to neutropenia and further, as we discussed in the earlier slide, it can be because of the fever causing neutropenia or the neutropenia given to a district infection and giving fever, verifying and qualifying the criteria. Initial workup is thorough review of the patient, look for any positive clue if you can assess from, if you could get from the initial assessment of the patient. This is a very simplified slide. Carefully search for well-being feeling. And due to investigation, initial full blood count, electrolytes, here the infected profile with lactate coagulation profile, then the vital organ assessment like urea, at LFTs, baseline chest X-ray, and then we need to take urine and blood cultures. And if we have any correction, the aspirate for that as well shall be cultured mandatorily. Evaluation and risk assessment that is done based on two algorithms. There are two major algorithms to be followed. That is called Multinational Association for Supportive Care in Cancer. That is called MASCC index. The other one is called CISNE score. That is Clinical Index of Stable Value. This is the MASCC score in which you categorize the patient into high and low risk. Please note that the major organ involvement like hypertension, chronic disease like COPD, like cancer, chemotherapy has been received, current status of dehydration, status at onset of fever and age of the patient. These all contribute to the MASCC score, which is usually applied for those patients with hemodynamic. This is the 5% if MSCC score is less than 15 gives you as high mortality as 40%, which is very. The other scoring system used for assessment of the patient is the clinical index of stable febrile neutropenia, as we already talked about that as CISNE score index, in which the patient categorized into high, low, and medium risk. This is the tabulated form. Based on the score, it is low, intermediate, and high risk. And please note that the results of a multi-center validation study suggest that the CISN score may be more accurate than MASCC score. Usually the reason we mentioned is since CISN score is mostly utilized in patients with stable neutropenia, and in stable cases the outcomes are usually predicted and unlike the unhemodynamic unstable patient where MASCC score is usually applied and those patients are more critical and hemodynamic control as expected as in stable patients. The vast majority of cases of this is the algorithm to the applied calculate MASCC score categorized into high risk and low risk. Please mention that. Please remember that the MASCC score we already talked about, if it's less than 15, it imparts a mortality of 40%, which is very high. The risk assessment, there have been so much new cases that score of 21 of state of development of fever, no concomitant diseases, no vital organ involvement, age of the patient, type of cancer, chemotherapy received, any other illnesses, fine. Also, these all contribute. The management of the patient, that is European Society of Medical Oncological, ESMO guidelines that we mentioned. Neutropenic patient presenting with fever, it's an emergency. It's a straightforward emergency. You should be treated immediately. Pregnancy is crucial. Cases of low risk, the patient, the treatment option. My Lord, growth factor that is in dementia patients mentioned in previous guidelines. The FDA have to share factors by listing various combinations of various preparations as evaluated in this test. Risk assessment profile access the disease, whether the patient disease is curable, whether the current condition is treatment intent or therapeutic intent, the current status of the patient prior to radiation assistant. Transplants and